All right, let's very briefly look at EEG changes during anesthesia. As I said, this is going to be very brief because other modules on ICE-TAP deal with this in much more detail. But I think in the context of this talk on intraoperative awareness, it's important to say something about the EEG changes with anesthesia, because I think that monitoring the brain is really very important. As way back as 1937, Gibbs and Lennox recommended that every patient should have monitoring of the heart and the brain during surgery. Sadly, we were delinquent in relation to monitoring the brain, although we were very efficient in relation to monitoring the heart. This is a slide from our review article on intraoperative awareness, and it shows examples of changes in a single channel EEG going from a wakeful state all the way through very deep anesthesia. And the general features that are notable are that you tend to have a shift from some of the higher frequency beta waves to more prominent delta waves, sometimes with sleep spindles in the alpha or theta range on those delta waves. And then eventually you get a suppressed EEG, maybe with bursts or without bursts, and then it's persistently suppressed. So the EEG changes from a higher frequency, lower amplitude pattern, generally to lower frequency and higher amplitudes, and sometimes with spindles like sleep spindles, analogous to the type of sleep spindles you see in non-REM sleep. And the motivation for using the EEG during general anesthesia, I'm sorry the writing on the slide didn't come up, but it doesn't matter. I will tell you what the motivation is. The motivation is that, as I was saying earlier, the brain is the target organ of general anesthesia. So having a direct monitor of the brain makes a lot of sense. Cardiovascular monitoring, like heart rate and blood pressure, provides surrogate monitors of general anesthesia. Similarly, even if you monitor an anesthetic concentration, there is inter-individual variability. So some people might be anesthetized at 1% isoflurane, maybe the overwhelming majority, but a small minority of patients might not be anesthetized. And conceptually, a brain monitor might help you to pick up the rare patients who would not be anesthetized with a typically anesthetizing dose of anesthetic agent. A brain monitor also should have a pretty rapid response time, especially if you're looking at the raw EEG trace. And intellectually, it's very satisfying for us as practitioners to be monitoring the target organ that we're actually affecting with our anesthetic agents. A montage is the placement of electrodes for an EEG. And we typically can't use a full EEG montage in the operating room because one, it would take too long to apply, it's not practical, and it's much easier for us where we have access to the forehead just to use a frontal montage or a bifrontal montage using two frontal or a single frontal channel. This image shows the 10-20 system for EEG placement. The left-sided leads have odd numbers and the right-sided leads have even numbers. So frontal, pole, frontal, central, temporal, occipital. And usually in the operating room we use from frontal pole 1 to frontal 7, which is the placement recommended for the BIS electrode, or on the right-hand side, frontal pole 2 to frontal 8, which would be a bilateral lead placement for two frontal channels, for example. And the reference could be to another lead or to a common reference, for example, at the ears. And that's for a general EEG. When we use the BIS, the reference is often here at the center, and there is a fourth electrode as well. I did go briefly over the waves, but the waves go from gamma through delta. Gamma are the highest frequency waves, and they go from about 30 hertz to hundreds of hertz. We don't measure gamma very well with EEG because they're very low amplitude and they're often filtered out by the scalp. Also, EMG, muscle activity, often occurs in the delta frequency, in the gamma frequencies, but can actually occur in the other frequencies. Beta is from 12 to 30 hertz and is often broken down into high beta and low beta, where high beta is 20 to about 30 and low beta from about 12 to 20. I should just stop at this point because I can see you're thinking, well, where do these things come from? I can see you are thinking that, right? In fact, they have no neurobiological basis. These are just arbitrary divisions of frequencies. They're not based on the brain doing anything differently at an alpha rhythm or a beta rhythm. They are correlates with different states, but there's no specific neurobiological basis to these arbitrary distinctions. The alpha waves are from 8 to 12 hertz, the theta from 4 to 8, and delta less than 4 hertz. And then below that you can get very low frequencies. We typically filter out at 0.5 hertz. And the frequencies below 0.5 hertz might be quite interesting, but we tend not to look at them. And then you get persistent suppression below that. This is an example of an EEG in the intraoperative period from an anesthetized person. And this shows a typical delta spindle pattern. And there are the delta waves, that's the underlying pattern, with alpha spindles riding on top of those delta waves. Rob Sanders and Jamie Slay, both of whom are friends of mine and colleagues, described this delta spindle pattern in a review article recently. It has been well described, but they have hypothesized that this delta spindle pattern occurs when there is hyperpolarization of the thalamus and the cortex, which would lead to breakdowns of communication between the arousal pathways and various cortical networks. And that when there is this delta spindle pattern, it is very unlikely that noxious stimuli would also be propagated. And this is an example of a delta spindle pattern with pure propofol anesthesia. This is one single EEG channel at 4 different sweep speeds. And I think at these 2 sweep speeds you can nicely see that slow delta pattern. And maybe at the fastest sweep speed you can appreciate the spindles riding on those slow delta waves. And then going deeper with general anesthesia, you go to this burst suppressed pattern. There's a suppression with a burst of activity. This occurs with very high concentrations of anesthetic agent. Also occurs with things like hypothermia, brain injury, or severe critical illness. Patients are more prone to having burst suppression. It is also possible that burst suppression occurs more commonly in very sick patients, and it is also more possible that those patients who get burst suppression do poorly in the long term. What we don't know is if burst suppression in and of itself is injurious or is merely reflective of patients who have vulnerable brains. However, it is worth considering that during natural sleep, we do tend to have the other patterns that I've referred to in previous slides, but we don't have burst suppression or persistent suppression. We certainly have a slow delta rhythm with sleep spindles during non-REM sleep, but burst suppression with burst suppression is not seen during normal life, which makes one suspicious that it is not necessarily a stage that we should be striving for during general anesthesia. And if our patients do become burst suppressed, we should think about withdrawing a bit of the anesthetic to try to get them back to a delta spindle pattern, although that has not been well researched to date.